All right. The intent is to have a code stroke plus talk. It's a process talk. It's related to quality, and it's related to performance improvement measures that Joint Commission has very dear to their heart. And as we move on to the next topic, which would be related to research quality improvement, we're going to start with the code stroke plus. When I started my code stroke life, it used to be called, we were the BAT team. And we somehow, during our fellowship, at one point, were able to manage to put on the Batman music in the background on the PA system of the hospital. That didn't go very well with our training program, but we were able to pull that off. So things have evolved. Things have become very streamlined. And we've had excellent relationship in a very multidisciplinary fashion with our out-of-hospital triage teams, with the EMS, with the emergency room department, with the radiologists, as we were discussing about this, and with our neurosurgeons to make a very comprehensive acute kind of a response to different strokes. We spoke about LVOs and recognition of LVOs and the scales that we need for LVOs, but the emphasis is for all patients with stroke to reduce the time that it takes to get them to the hospital. For the large vessel occlusion patients, it is to provide them with recanalization, and the recommendations that we put forth has to come with the community education. We talked about how Duke University is trying to promote programs where the pastors are involved, where the churches are involved, where even the barber shops are involved, where they're snipping stroke. There has to be rapid recognition of stroke symptoms. There has to be a rapid pre-hospital assessment. We need stabilization and imaging modalities that are limited, don't waste time, but provide us enough information to get the patient to endovascular suite if that's necessary for the patient. So we directly get the stroke patient to the CT in many hospitals. And this is where we evolved our algorithms, and they became more and more complicated. There's a big complicated slide there. The reason I wanted to show you this slide, this is kind of like the paradigm that we follow, is where the code neurointervention, a new code, gets in the code stroke acute pathways. We decided that just calling a code stroke and then having a discussion with the neurointerventionalist was not good enough. It wasn't fast enough. So we instituted code neurointervention, and that's what I'm going to talk about first. But as the treatment modalities for acute hemorrhagic strokes become available too, we're going to talk a little bit about the code brain bleed. So we became a network too, like many other places. We carry this round logo of Hackensack Meridian Health University Hospital. It has 3 comprehensive stroke centers, 16 smaller primary stroke centers, and we are one of the comprehensives. So the first initiative we did was that after the 2018 guidelines came out for acute stroke management, we decided that we're going to have a practice management for everything stroke related, including TIAs, including hemorrhagic strokes, and subarachnoid hemorrhages. So we developed guidelines. But guidelines are not pathways. Guidelines are not where the teams unite in an acute situation to provide care. Guidelines can be followed, may not be followed. So we thought that there was a need based on the landmark studies in 2015 that early reperfusion needs to be performed. We knew that the sooner the groin puncture time was, higher recanalization rates were associated with clinical outcomes, and we don't need to go through all of that again. But 2015 was really a watershed historical event for all of us in this room who care for the stroke patients. So advanced neuroimaging was another modality that has been talked and discussed about in this conference so far a lot. Whether it needs to be that advanced or not, even You saw Dr. Jovin and Dr. Noguera supporting the idea that maybe more basic imaging for some select patients should be good enough. So this is another factor that code plays into it. So how it used to go was that the acute stroke team would discuss the patient with a neurointerventionalist. And this was based on the patient's presentation, NIH stroke scale, advanced imaging modalities. We were at that time very confused. We were doing acute MRIs for some patients. We had a very complicated algorithm, doing CTs, CT perfusions, and would have a discussion with the stroke team, and the stroke team will personally notify the interventionalist. It led to delays in treatment. There was extra time needed for acquisition and interpretation of advanced imaging, and the patient preparation times were long. The time matrix that we were seeing, including the door to decision time for neurointervention and groin puncture or skin puncture for radial access, was very long. So what we decided was compare the institution of code neurointervention, a process whereby code stroke alert, like after the modification of the code stroke alert where the patient comes directly to the CAT scan, the rapid assembly of neurointerventional team is done by the stroke team. So the stroke team decides to call the neurointerventional team in. If they don't like it, they can go back home and they can decide to call off the code neurointervention, but at least they had to respond within 30 minutes and be there physically with the patient. So stroke team determined who was a patient for neurointervention, and the stroke team would alert the code NI. NI team members were paged, group paged, and there was an algorithm that was followed. Patient was prepped and in the emergency room if it was after hours. If it was not after hours and the team was present and the angiography suite was available, the patient was immediately rushed to the angiography suite. A lot of education had to be given to the ER nurses, physicians, as well as the rest of the radiology teams in the hospital. So when we looked at our data, we split it up into the pre-code NI data and the code NI group, which is after 2014. And this is the mostly a pre-dawn data, so our times are much better now. We pretty much collected basic information on door to puncture time, door to recanalization times, pre-procedural NIH-SS, and at 24 hours, and the modified Rankin scores at 3 months. So what you see over here is there's a huge improvement in the mean procedural times. The times are very long because this includes all procedure. This is not like a select group of just interior circulation, just M1s. This is basilar occlusions, distal M2, M3 occlusions. So the mean time from the pre-code NI of 161 minutes improved to 115 minutes. So we got it less than 120 minutes. At that time, that was our goal. Now we are trying to focus for a goal for 90 minutes with a 30, 60, 90 paradigm. And the door to recanalization time improved from 220 minutes to 166 minutes with just the institution of the process itself. There was a supportive and a correlative improvement of 3-month modified Rankin score with a mean from 2.15 to 1.65. So some limitations, there was inadequate and inconsistent data before the institution of code neurointervention. There were some problems with requiring education, so we continue to see the improvement over time with the times. There was a neurointerventional kit that we had to make for the nurses, the emergency room nurses, to be prepping the patient, putting the Foleys in, and the orientation to the biplane angiography suite, including where are the medications, how do they get the IV drips, everything had to be taught to all the nurses in the emergency room. In conclusion, the institution of cord neurointervention was a significant improvement for a door-to-puncture time with the modified Rankin scores that supported that you're actually doing something that is more rapid with safe outcomes. These lessons were widespread, and we think that this is going to become a norm across, that there'll be some kind of a cord stroke plus process. We think that different components of this needs to be addressed and education given. So Joint Commission right now is on a mission to improve processes, to set standards for times, but very little has been done on the outcome side of things. And that's where we think the process improvement would evolve to. So it shouldn't be just limited to a systematic approach of closing process system gaps through streamlining and like reduction of times. There has to be identification and elimination of causes. So it requires a deeper dive. Performance measures are something that can competently and safely deliver appropriate clinical services, but still does not look at the outcomes. So these are the specific measures that we look at right now for the primary stroke centers. All of you are familiar with that. And this is what we look for the comprehensive stroke centers, the CSDK measures. I want to focus, and I'm showing you this, I want to focus on the measure number 3, because that pertains to intracerebral hemorrhage and subarachnoid hemorrhages. Early deterioration is common in both of these conditions, and we know that there's an increased mortality rate. And over half of these deaths happen within the first 2 days. So there is evidence-based guidelines from American Heart Association. We do know that the volume of intracerebral hemorrhage and perihematoma edema as it expands. This is data showing that on the x-axis, if the volume goes above 5 mLs is when you can become symptomatic, and the time that it increases can start to increase within 6 hours. So 6 hours is usually the time cutoff for many centers to do a repeat CAT scan to see if there is volume expansion or if there is hematoma expansion or perihematoma edema expansion. The guidelines suggest that there is a huge downside of either a re-rupture of an aneurysm or expansion of the hematoma. How comprehensive stroke centers measure it is still very archaic. It's still very basic. The CSTK3 just wants us to document a scale within 6 hours for subarachnoid hemorrhages and intracerebral hemorrhages. That's all it requires us. And we, as proud as we are to have a great system, a great comprehensive stroke center, we take care of more than 150 to 160 thrombectomies every year, more than 100 TPAs, so acute stroke volume is more than 250. Big center, but when it came to the measures that make a huge difference in these patients, where they can have a huge mortality with high ICH scores, we were missing out even on the scores. Forget about the possible interventions that could benefit these patients, and is an evolving field that I needed to address in these processes that involve acute stroke pathways. So Hunt-Hess scales, also an important score to have in your mind within an acute period for stroke. We were not capturing this. Our data, 2015, 53% capture of documented within 6 hours the scores. 2016, 68%. 2017, 70%. So quarter 1 and 2, it was in 2018 was 50%. So we were having problems. And we weren't even able to capture a score of severity that would portend a poor outcome for the patient because by the time it got captured, it was almost always beyond 6 hours. And when we were on the paper charts, of course, we could finagle our way through, but like with Epic, everything is documented, right? Like, so it's tough to change the timestamp there. So we said that we need to do something about the code strokes that are bleeds or just bleeds that are not recognized as strokes, and the patient comes in with either mental status changes or they're having some other difficulties and they're not recognized as strokes. Those were the people that we were mostly missing. Somebody with hypertensive emergency, urgency. So we instituted and thought about instituting a code brain bleed. And the purpose of this code was going to be rapid notification assembly of the stroke team and neurosurgical team for immediate evaluation and treatment of patients with subarachnoid hemorrhage and intracerebral hemorrhage. So I say stroke team here. At Stroke and Neurovascular Center, our stroke neurocritical care teams are together, so that means, at least in our center, neurocritical care team also. So there was a rapid notification of neurocritical care and neurointerventional teams for this code as well. So writing the policy, getting help from our education department, and again, educating the nurses and staff on another code. So now there's a code brain bleed, right? Like, so there's code stroke, code neurointervention, code brain bleed now. And for our code stroke, there is a direct to CT code stroke, and then there is a code stroke in the emergency room, so there are different pathways for those. So we had to develop pathways, and we recognized that there are some bleeders who would come with the code stroke already called on them versus those that are identified as non-code stroke and would come separately. And there had to be some kind of a process in the inpatient unit, and there had to be a process in our satellite emergency unit, so it became a bigger project than we thought it would be. But we got to our objective. We got a documentation of our severity score of 100%. So should we call this a victory? In this situation, perfection is boring because we haven't even touched the outcomes. We are just looking at the process of documenting a measly score in a center that we are very proud that it's a good stroke center. So is there a need and a gap for pathways to exist beyond code stroke? I really do think so. What is the future? We thought the future is that we have to develop a pathway for pediatric stroke because we were not doing a good job with the regular stroke pathway. The pediatric neurologists were not getting alerted. So now there's a design in process, and I don't expect you to read off the whole flow chart, but the design in process to develop a pathway for pediatric stroke. What is next? We think that pediatric code neurointervention is entirely a separate thing. And we are in the process of having our MRI being available 24/7 with the techs being available in-house, so an MRI can be done in an expeditious fashion. Before, our techs were not available from 11 to 7 a.m. Anesthesiologists have to be available for pediatric code strokes and code neurointerventions. So there are things that need to evolve, and the whole hospital has to come together, and educating the pediatric emergency room for the processes that are taken for granted on the adult side of emergency room is very different. So we do need to think as a community together that is code stroke good enough, or do we need to evolve ourselves to start new codes, or should we just expand what exists? There has to be a code stroke direct to CT, code stroke for transfers, code neurointervention, code brain bleed, and then pediatric strokes are completely different. So we're going to start with a code stroke, then go to pediatric code neurointervention. Does that mean that we would need a pediatric code brain bleed? I don't know. Thank you very much. That's all I have.